Hi all, and welcome to this webinar about Effexor withdrawal and safe tapering principles. We're so excited to have you today. We're going to get started in just a minute. If you want to say hello in the chat, looks like some people are already introducing themselves, explaining where they're from, what brings them to today's webinar. Please feel free to do so. Also, as we are chatting, about the first 30 to 40 minutes of today's presentation will be more educational in nature, and then we'll save quite a bit of time towards the end for a Q&A. So if any questions come up during the presentation, feel free to drop them in the chat, and then we will try to get to as many questions as possible during the Q&A portion. So we'll go ahead and get started. Going to wait for the slides to come up.
Welcome, everyone.
All right, so we'll start with some introductions. My name is Charlotte. I am currently based in Colorado. I'm trained as a primary care nurse practitioner, and I'm also a student in psychiatric mental health nursing at Johns Hopkins University. I'm also a health coach, and I'm also, importantly, someone who's been on antidepressants and had a really challenging time tapering off of them. Here at Outro, I work as the lead nurse practitioner, and I am so excited to see how many people are joining us today for this really important conversation. And I'm really excited. I'm joined today by Dr. Bryan Shapiro, who is our medical director at Outro, and I will pass it to him to introduce himself some more. Hi, Bryan. How's it going?
Good, Charlotte. Very nice to meet everyone. I'm Bryan Shapiro. I'm a board-certified psychiatrist at UC Irvine Medical Center, which is in Southern California. I do a mix in my academic practice. I do a mix of consultation-liaison psychiatry and outpatient practice. I'm tasked also with teaching the psychiatric residents about psychopharmacology. I'm also in a national program where I teach primary care doctors how to conservatively prescribe and deprescribe psychiatric medications. As is the case with many people in this space, I also had a personal experience on antidepressants. I was prescribed Paxil when I was about 8 years old for separation anxiety disorder. And one of my early experiences, my early memories, is having to go into my mom's bedroom to take little slivers of Paxil to help get off of it because she noticed that I really wasn't doing well going with the doctor's advice. And so ever since then, I've been very, very much oriented towards deprescribing, how to safely prescribe and deprescribe psychiatric drugs. And I'm really excited to talk to you all today about one of the high-risk medications, venlafaxine or Effexor.
Thanks so much, Bryan. So excited to have you here today. So when we think about deprescribing, there's this question that comes up very frequently at Outro, and that is, why do we want to deprescribe? We could go to the next slide. So, as the lead nurse practitioner at Outro, I've seen a number of patients come through our door since we launched in June, and there's a lot of reasons why people have come to Outro and looked for help with this. So side effects are a major thing, things like sexual side effects, weight gain, etc. And Bryan will speak on those in more detail in a moment. A feeling of not needing medication anymore. And oftentimes another reason people will come is that they feel like they have a combination of many different medications. This is called polypharmacy. So feeling like they're on a cocktail of medications and really want to simplify or come off. Bryan, could you speak a little bit more on what you found are reasons why deprescribing is really important?
Yeah, just looking at the graph on the right, there's been a 5-fold increase since 2000, and this data isn't even that recent in the amount of people taking these medications long term. 1 in 8 American adults in the US is prescribed an antidepressant, and women are certainly overrepresented, about twice as high prevalence as men, and also 1 in 4 women aged 60 or older in the US is prescribed an antidepressant. So this is something that's very common. In terms of why it's important to deprescribe, there are many reasons. Very often the medications are prescribed in a primary care setting, and there isn't really enough time to accurately diagnose. These medications are often prescribed for kind of what we call adjustment disorders or stress, and not for a severe primary psychiatric condition. And so patients are put on these medications without an endpoint. And in psychiatry, there's very often what we call clinical inertia, where patient says that they're doing well, and so we just feel it makes sense to just continue the medications, and this can go on for months and months to years. with consequences once we think about deprescribing and tapering off. Um, Commonly, patients report side effects that don't go away. There are usually acute side effects, early side effects, things like nausea, sometimes insomnia with these medications. Those in most people tend to dissipate over a matter of weeks. But chronically, we see a lot of the key word is numbing, sexual side effects, emotional numbing, where yes, it might help the lows a bit, but things that would normally give a person joy, just it's a little bit subdued. Many patients feel like they just can't cry, they can't express emotion. This is something that I would say in at least 50% of patients we see numbing, sexual numbing or emotional numbing. And then we have sort of the insidious, sort of idiosyncratic, like feeling very tired um, during the daytime and not really knowing why. It's actually a product of their antidepressant. And then there are medical reasons why it makes sense to deprescribe. I've seen patients on Prozac who are prescribed tamoxifen for breast cancer prophylaxis, and several SSRIs interfere with the ability of drugs like tamoxifen to actually work in major conditions like preventing recurrence of breast cancer. And so we see in the consult service in the hospital, I see drops in sodium levels, I see increased bleeding risk, and there is an urgency there to look at the medications, and very often that compels a reduction or a complete cessation of these drugs. So there are many reasons to deprescribe.
Yeah, absolutely. On the topic of emotional blunting, there was a patient that I saw who had such a beautiful analogy I wanted to share, and maybe this is something that people in the audience have experienced. The sensation that they were sitting at a piano, they said, and that the keys were the different range of their emotions, and that they could see the highest and the lowest keys, the highest and the lowest emotions, but felt like they were unable to access them via being on these medications. So that blunting and numbing effect seems to be something we see a lot here at Outro. And so the question, if we could go to the next slide, is that many patients feel as though when they go to their primary care provider or go to their psychiatrist, that it is challenging to get support with tapering or coming off of these medications. Some have told us that they have been outright told by their psychiatric provider or the person who is prescribing their medications that they would not support them in tapering. Others have voiced that there's just not a lot of information out there on how to taper, so there's some uncertainty from providers on how best to taper. And so
Yeah.
many people have turned to these online support groups, which are a beautiful kind of fill in for the need for us to talk more about tapering and a resource for patients. And Bryan, I was wondering if you could talk a little bit about this kind of gap in the education that we see with access to safe tapering protocols.
Yes, the issue is that this is not in the curriculum when psychiatric residents are getting trained. Um, the guidelines are very vague. At least in the U.S., the American Psychiatric Association is considered a relative authority, and their recommendations are simply to just taper over a few weeks without any nuance or consideration of the different types of antidepressants, the rate and duration of tapers, and even worse, providers might not even believe in antidepressant withdrawal at all. Very commonly, and we'll talk about this a little more, is any symptoms in the setting of tapering the medications is interpreted as a relapse or recurrence of the original condition for which the drug was being prescribed, or also very often a concern for a new medical condition. Let's say there's paresthesias or tingling in the body. Patient gets referred to neurology and undergoes an extensive workup. But it's really completely missing this really underappreciated, underrecognized issue of antidepressant withdrawal. And so part of my role as a psychiatrist, as an academic psychiatrist, is teaching residents and teaching primary care physicians around the country to look out for antidepressant withdrawal, to make sure you're tapering appropriately and correctly under the hyperbolic approach that we'll talk about in a moment.
Thanks so much, Bryan. And just a note to those who are listening and in the chat, thank you so much for sharing with us that you're having trouble hearing. We'll do our best to speak up a little bit more loudly, so hopefully the volume comes through. But thank you for keeping us posted.
Yeah, and so withdrawal is actually really common, and it's proportional. And this is the danger in that clinical inertia I was talking about, where the drugs just stay on for months and months to years, is that the longer the patient is on the drug, if you look to the right, you see the duration of treatment on the x-axis. On the y-axis, the proportion of patients. It does plateau maybe after 2 or 3 years, but it really matters if you're on the drug for 1 month versus 6 months versus 12 months. It can lead to much more severe withdrawal symptoms. And this isn't even discussing, the specific type of antidepressant. This is just the duration of treatment. I would say it's at least half of patients will experience very severe withdrawal. It is not mild and self-limited, which is how it was originally presented by this consensus panel that informed the APA guidelines. These can be debilitating, could lead to missed work days, can have devastating consequences in terms of social or occupational functioning, and so a real problem. And as I alluded to earlier, withdrawal symptoms are very often mistaken for relapse. One of the clues that you're experiencing an actual withdrawal syndrome as opposed to a relapse are the physical symptoms. And I think one symptom that's actually quite specific for serotonin withdrawal are the electric shocks, the brain zaps, that are made worse when you turn your head. It feels like your brain is rebooting, and it can be very uncomfortable and destabilizing. That's one of the most common ones I see. Dizziness, irritability, anxiety. It's definitely a mix and a constellation of emotional and physical symptoms, but you should really key in on the physical symptoms as a provider, because many patients experience them. They can be immediate. Typically, one thing I do to screen for patients who might be at high risk for withdrawal is I ask, whenever you're on vacation, whenever you miss a dose of your medication, what do you notice? And those are the symptoms I'll want to watch for when I'm tapering a patient off of their antidepressants. There are very often delayed reactions that go beyond, the onset goes beyond what we would expect based on the half-life or the time it takes for the body to start to remove the drug. And it's typically alleviated quite rapidly with reinstatement of the medication, but this is not an absolute rule. And the issue is that these withdrawal symptoms, if they're not addressed appropriately, can go on for months, years. We really want to do it right the first time, because sometimes when there's an abrupt cessation of the drug, it just sets the brain off on a path of stress, of trauma. It's hard to restabilize. So it's really important to do it right the first time.
Yeah. We have a lot of people in the chat talking about their withdrawal symptoms, tinnitus, anxiety, brain zaps. It sounds like there's a lot of resonance with these symptoms that people have experienced.
Yeah. And so as part of my journey in this area, I started to look at the data, and I was wondering, why is antidepressant withdrawal so common despite these tapers that we do? So I was noticing, I would taper patients within the therapeutic dosage range. Maybe for people who have tried Zoloft, to going from 200, down to 150 to 100 to 50 milligrams, but patients would still experience withdrawal. And so there was a real revelation integrating what we learned from brain imaging data, finding that you really need to use what we call sub-therapeutic dosages to mitigate withdrawal symptoms. So going lower than the usual therapeutic range is absolutely essential, because these drugs follow what I'll present to you as a hyperbolic pattern in terms of their occupancy of their target. So and Mark Horowitz out of the UK did he really pioneered this method and elaborated and characterized how this looks for each individual antidepressant drug. And this is super important in alleviating withdrawal symptoms. It is really, I think, the only way to successfully taper and wean the patients off of these drugs without causing some sort of major problem or disaster or major impairment in their functioning. So this might look a little intimidating as a graph, but there are a few principles I want to talk about. The body always tries to maintain a homeostasis, kind of a set point, a comfort zone. And when you initially start an antidepressant, that kind of homeostatic point adjusts and it normalizes somewhere as it gets used to the medication. Now, the issue is that your body adapts to the antidepressant, and then if you abruptly pull that medication away, that is a major, major disruption to the homeostatic set point, and your body reacts with all sorts of symptoms to this disruption. And so if you look at the bottom, tapering the drug, when you make incremental changes, let's say every 4 weeks, the magnitude of that disruption is less. And so that's very important to do and to do carefully so that we cannot disturb, the body's homeostasis, which can set off a real chain reaction of all sorts of psychological and physical symptoms. And so we like to do this carefully and slowly. So if you look at the bottom graph, the slower and more carefully we can do the incremental reductions in the antidepressant dose, the easier we can make it for the patient, even if it does take months, even in some cases years. This is the way to do it to reduce the risk of really damaging kind of withdrawal symptoms.
Dr. Horowitz also describes it as walking down the steps. We're creating a staircase that we can walk down of the dose rather than having to slide really quickly, as per that first graph, from a higher dose down more quickly.
So our drug of the day, we're going to talk today about Effexor, venlafaxine. I wonder if it has a different name in the UK. I don't think so, or other places in the world. Psychiatrists often prescribe venlafaxine or Effexor as an option if their original SSRI, for instance, is not working to treat anxiety or depression or PTSD. It is usually a second-line option because as an SNRI, you're adding a new neurotransmitter, norepinephrine, into the mix. And very often that comes with additional side effects such as constipation, nausea. And so we like to try an SSRI first in practice before we explore this. So typically it's for patients who psychiatrists label quote unquote treatment resistant would be introduced venlafaxine. Off-label, because of that norepinephrine effect, it's sometimes used for neuropathic pain conditions or chronic pain, much like duloxetine or Cymbalta is, although it is off-label for this purpose. So things like diabetic peripheral neuropathy, fibromyalgia, chronic musculoskeletal pain, very often venlafaxine will be introduced for that purpose. Something unique about venlafaxine that I learned in residency is that it's a little bit more dangerous in overdose. And that's probably because of the sodium channel blockade properties that affect the heart. And then the reason that's important for withdrawal is that I've seen in practice people report more paresthesias, tingling, like neuropathic kind of complaints during venlafaxine withdrawal, which can be really debilitating. And I think that's probably related to this additional receptor target, which are the sodium channels. When we are trained in terms of withdrawal, I mean, what we will hear, if anything, is that Paxil and Effexor are typically considered highest risk. Now, I consider most of these drugs to be extremely high risk in terms of withdrawal, but there is one property of venlafaxine that makes it quite severe, and that is the very short half-life of the drug. Half-life is the time it takes for the body to clear about 50% of the drug, and so it's quite volatile. The drug itself the half-life is just 5 hours. Most antidepressants are about a day. Prozac or fluoxetine is much longer, about 2 weeks. And so it's metabolized to another antidepressant drug called Pristiq, which itself has not a good, very, very, very challenging in terms of tapering because of its withdrawal risk. So it's a very short half-life drug. When you're tapering this drug, it does follow the same properties of a hyperbolic. You need to taper it hyperbolically because if you were to reduce it within its therapeutic range, let's say 300 to 250 to 200 to 150 to 100, you're making very little headway in terms of its receptor occupancy. And we'll look at that in a moment. But this drug, I don't prescribe it because of how hard it is to taper. With the Effexor, the capsule inside of it are beads, and many patients have to resort to bead counting or bead weighing in order to successfully wean their Effexor. And we'll talk about that also a little bit more in detail in a moment. And so here's kind of what we're talking about. I'd like you to kind of look at the right side in that black curve, and just to orient you, on the y-axis, going from top to bottom, is the occupancy or the effect on its target, the serotonin transporter, and on the x-axis, going horizontally, is the dose of this drug, of venlafaxine. And you'll notice, I mean, the typical therapeutic range of venlafaxine is between 75 milligrams to maybe about 225, sometimes up to 300. You're going to see there's very little change in the effect on that receptor in that therapeutic dosage range. But where the gradual reductions in serotonin occupancy happen is when you start to get to subtherapeutic dosages. So this is a huge problem because the dosage formulary is not very conducive to these subtherapeutic reductions. And so we need to be more creative and find out new ways to help patients get off of this drug slowly, because it's not just the half-life that matters, it's the dosage formulary that matters. And the formulary is based on efficacy. It's what they feel is helpful. They're really not thinking about what is required to help get the patients off of the drug successfully. So we really need to use those subtherapeutic dosages to effectively get patients off of this drug without severe withdrawal symptoms. Charlotte, I think you're muted.
Excuse me, sorry, I was muted. But a really important point that I want to make, there's a great conversation going on in the chat right now about sort of the genesis of hyperbolic tapering. And I do think it's important to note that, as Mark Horowitz did a lot of the research on hyperbolic tapering and helped to prove some of these concepts, we, here at Outro really are indebted to in the lay community and the peer support groups that brought forward this movement and brought forward the importance of hyperbolic tapering. So I really do want to mention that and express our really eternal gratitude for that.
Yeah, and so here's, with Outro, for instance, this is what we might look at in terms of let's say we have a patient who's been on Effexor, and we see it all the time, 10, 15, maybe, 10, 15, 20 years. How might we taper this drug in a patient who's been on this medication for so long? Now, we already saw that the duration of antidepressant exposure correlates with the risk of withdrawal. And so to a typical psychiatrist or primary care doctor looking at this might think this is crazy. This might take months or even up to a year or two of tapering this drug. But this is absolutely crucial in successfully weaning the drug. So a fast taper, and I like reductions in increments of every 4 weeks, because this is typically how long it takes for the body to adjust to a dosage reduction to achieve a new homeostatic set point. And so a fast would look like a 10% reduction, and these reductions are carried forward. It's not like you go, from 300 milligrams to 270 to 240. It's not a linear change. It's a hyperbolic change. And medium might be 5%. Slow would just be 2%, 2.5% reductions carried forward until the duration is complete. And just as important as this pace, the percentage reduction is that last dose that you get to. You really want to make sure that last dose is at a very low receptor occupancy before you actually stop treatment. And as some examples, Mark Horowitz recently published the Maudsley Deprescribing Guidelines, which I think is an excellent guide, going into the nuances of what these tapers might look like based on the hyperbolic model. And so every step might be every 4 weeks. We like to look at receptor occupancy as a function of dose. We're often using liquid dilutions to help achieve those those intermediate or subtherapeutic dosages. And we'd like to get patients down to at least 10, maybe 20%, hopefully less occupancy, depending on the patient preferences and our shared decision making before we stop. A medium taper is a little bit slower, and you'll see these are very, very low dosages. But what the hyperbolic model teaches us is that these are absolutely crucial to successfully wean these drugs. Slow taper, even slower. Now, you might even notice that initially these numerical dosage reductions are actually quite large, and they get lower and lower, and more minute, more granular, smaller as we get to the very low dosages here. So that's just following the hyperbolic model. You can see the receptor occupancy changes are negligible initially, but become much more significant, and so we have to taper slower towards the end.
So for this next part, we really want this to be an interactive Q&A. So these are just a couple questions that we've received quite frequently here at Outro, and we will also be answering questions from the chat. But one kind of starting question for you, Bryan, is, what makes Effexor specifically so much harder to stop than other medications? You touched on this before, but why is this one so hard?
Yeah, I'm really excited to get to the discussion. It sounds like we have a lot of great questions. These are great questions. I think it's a combination of a few factors. First is the very short half-life. It's just extremely short. 5 hours for the active drug, 11 for its metabolite. Very, very short. The second are probably the off-target receptor effects, such as the norepinephrine, because when you're taking a drug that has multiple receptor targets, you're not only withdrawing potentially from the original, like one of the targets, the serotonin transporter, you're also potentially withdrawing from norepinephrine withdrawal, essentially, or from sodium channel blockade. The more targets, the more there is to withdraw from. So that is another factor. The third is the dosage formulary, which really is not conducive to a gradual taper. Almost as bad as duloxetine or Cymbalta, but it leaves patients in a very, very difficult place where without much support, I mean, they're forced to try to weigh or count beads and those sorts of things. So a lot of challenges with Effexor.
Yeah. Another question that we frequently get here at Outro is how to get to these smaller doses below 37.5 milligrams, for example, which is the smallest available commercial capsule for Effexor. And Bryan, I don't know if you want to kick this off, and I can talk a little bit more about what we do at Outro specifically, but how do you help people get to these smaller doses?
Yeah, great question, Charlotte. And as we saw from the other slides, I mean, 37.5 is just the beginning in the journey. What I've done in practice is not having Outro. I've had to pivot from the XR formulation, for which the lowest dose is 37.5, to the immediate release, which you can get to there's a 25 milligram score tablet, which enables you to at least get to 12.5 by scoring the tablet. But man, you're really rendered with the option of either getting these drugs compounded, opening the capsules. It's quite hard to get to those low dosages.
Here at Outro, oftentimes we use custom compounded doses of medication. So getting down to lower doses, we can compound that either as a liquid preparation or as a compounded capsule preparation. If you do not have access to a compounded pharmacy, another thing that people oftentimes do is bead counting or bead weighing. Bryan, I was wondering if you could speak on that a bit.
It's exactly what it sounds like. It's opening the capsules, and these, I mean, there's just hundreds of them, and they're extremely tiny. There's also the problem is that there's discrepancies in terms of the weight and the size of the individual beads. They're not all the same size and weight, which can be problematic and can require weighing. I mean, it's just very problematic for patients with physical or cognitive limitations, and to do this for months or years on end is extremely challenging and time consuming. And it's really not ideal, but it's often what patients have to resort to.
And I'm curious if you could speak on what the difference is between Effexor and Effexor XR. Oftentimes when we compound medication, we don't use an XR formulation. So I was wondering if you could talk about the different types of venlafaxine or Effexor that are out there and available.
Yeah, so Effexor XR, it's extended release, and so basically the capsule, the beads themselves are coated with a polymer that releases the drugs more on a more extended basis, and also the capsule itself has more of an extended release kind of coating. What's interesting is that there's a misconception that the half-lives of an extended release and an immediate release are different. They're actually the same half-lives. It's just it appears, it's called the apparent half-life. It appears that the half-life of the Effexor XR is longer because the drug is being slowly absorbed. But let's say the Effexor XR and Effexor IR are in your system. Once they're in your system, the half-lives will be identical. And so it makes no difference in terms of withdrawal risk.
Okay. There's a lot of questions coming up in the chat that I wanted to clarify as we were just talking about bead counting, but there's a lot of questions around, do all types of Effexor contain the same number of beads, and do all of the different beads contain the same concentration of drug? And my understanding is no, it's dependent on the manufacturer. Is that correct?
It's dependent on the manufacturer, but even within manufacturer, it depends on the batch. Because the polymer, the amount of polymer around that's surrounding each individual bead of that's surrounding each amount of Effexor within the beads actually varies. So it depends on not only the manufacturer but the batch itself.
Okay. Yeah.
These are generic drugs, so there can be multiple generic manufacturers. Patients are often like, they're like, oh, my drug looks different. Pharmacies can switch manufacturers on a regular basis.
Yeah, we have many patients who come to us who, previously were counting from a 240 bead capsule, and then their manufacturer switched and suddenly they were found with a 100 bead capsule. And there can be a lot of discrepancies and challenges with bead counting accurately from that standpoint. So definitely some really great questions. The lifestyle changes question, I think if it's okay with you, Bryan, I can take that one about how can some of these more adjunct or integrative modalities be helpful with during the taper process as well as after. I think that one of the major things we see is the importance of having some sort of therapeutic alliance or support during the taper. As many people are mentioning in the chat, this can be a very long road, and it can also be a very scary road. Right? Many of us have been on these medications for many, many years, perhaps decades. And so the process of tapering off can be a long one. And to have a partnership with somebody that you trust, a therapeutic alliance, whether that is with a therapist, a social worker, a psychologist, a psychiatrist, a mental health practitioner, a coach, that you can work with longitudinally to help when distress arises and have a game plan of how to tackle when side effects come up. I think that therapeutic support is one of the most important things I see. We'll do other future presentations on other ways to bring in different lifestyle modalities, everything from breath work to the importance of nutrition to the role of supplementation. I know that there's been some great questions in the chat about those as well. But for now, I'd say, I think that having an alliance with someone you trust and someone that you feel safe talking to about this journey is one of the most important things that I've seen in terms of positive outcomes. And so just to kind of give a little plug for Outro, Outro is a complete telemedicine solution for antidepressant deprescribing. We helped customize personalized hyperbolic tapering plans. You have regular visits with a clinician who is versed in antidepressant tapering, withdrawal, and discontinuation. You have the ability to asynchronously message with your clinician between visits, as well as monitor your symptoms via symptom tracking. There's also access to compounded medications, depending on which state you are residing in. We have partnerships with various compounding pharmacies, and we're constantly expanding our services. So I know there's a lot of questions in the chat about when we will be in all 50 states, and that is coming. That is our hope in the coming months and years. And you also receive access to personalized lifestyle medicine support. Currently, we are with our taper management program. This looks like initially a series of onboarding questions, an initial consultation, which is a virtual visit with your clinician, which really helps do a deep dive into your history, your eligibility for our service, From there, there's a taper initiation that's set up, and that's where we really get into what I call the nitty-gritty of your taper plan, of exactly what your medication dosage will look like, what your taper plan will look like, and then getting that first prescription out the door and sent to you. And then follow-up visits every 1 to 4 weeks to assess your progress, make further dose reductions, check in about symptoms, really help fortify your mental health toolkit with these other lifestyle integrative practices, and so on. And so Outro's clinical leadership team, we've alluded to Dr. Mark Horowitz. He is our co-founder and a world-leading expert on deprescribing. Fantastic person. You'll see him around Outro on webinars, on our website. Dr. Bryan Shapiro, our wonderful medical director, who's doing also just so much incredible work in this space. So I want to just take a moment and thank everyone for just this really riveting, important discussion that we're having in the chat. And thank everyone for their questions so far. We'll just take a moment if anyone wants to throw any additional questions, any thoughts, any feedback, anything at all in the chat, and then we'll take the last 20-ish minutes to answer questions from the audience.
All right, we got a question from Brittany. If you start with a lower dose and you're on for a shorter period of time, would it be hypothetically easier to taper off? Yeah, I mean, we really personalize things depending on, we really go into the nitty-gritty details. We're all about details and how long it's been. Is it 1 month? Is it 3 months? Is it 6 months? Those details make all the difference. The lower the dose you're on, yes, the taper will be shorter, but as I've mentioned, those lower dosages are a very sensitive point, a very sensitive area in terms of withdrawal risk. So we have to be very careful and nuanced with that taper. Yeah, and I'm seeing a lot of interesting remarks about when you're switching formulations of the drug, like going from XR to IR from a different manufacturer, and the real issue is that it can vary up to 20%. The amount of drug from manufacturer to manufacturer can vary 20%. So even though you're taking the same dose, there might be a significant reduction in the amount your drug you're actually getting that could put you at risk for withdrawal. So that's why we like consistency and why we work closely with our compounding pharmacy to make sure it's very consistent what you're getting from beginning to end. Taper. Cymbalta or Effexor, which one is more potent and which one is more difficult to withdraw from? So they're both extremely high risk. I think, in my opinion, Cymbalta, I mean, if it's even possible, I think it might be even a little worse. And that's not even related to the pharmacology because the half-life is about 12 hours. It's a little bit more potent of a norepinephrine reuptake inhibitor, which could increase risk of norepinephrine withdrawal. But also, you can only get down to a 20 milligram capsule, and there's no scorable tablet or anything like that. It is a major problem that I think we are well poised to help with at Outro because of what we can do with in terms of compounding.
Another question that came up. Oh, go ahead.
When I've tapered before, doctors want to cross taper to other SSRIs or SNRIs, but that makes matters worse. Can you speak to this? Yes. It depends on why they want to cross taper. Sometimes there's this Prozac switch strategy where they try to switch you to a longer half-life drug in order to potentially help you get off of the original one, and then you have to taper the Prozac. It's hard to do correctly. I think switching to a different SSRI, SNRI just kind of prolongs the problem without actually helping you get off completely if that's your goal.
Another question that came up earlier in the discussion was around the mechanism of action of venlafaxine. And there were some questions about at higher doses, specifically above 150 milligrams, if venlafaxine only acts on the norepinephrine receptors or if it also is interacting on the serotonin receptors. Could you speak to that?
I've gone down this rabbit hole, and if you look, I mean, I've looked at brain imaging studies from rats, and like which dose correlates, with because it's like a kind of a stepped pyramid kind of thing. It's hard to say, but it probably starts affecting the norepinephrine system even as low as 75 milligrams as it starts to saturate the serotonin part of that step ladder. There's also this question I saw from Karina. And this is kind of important to me to mention. She talks about evidence after tapering that your brain has changed. I believe that they cause, I believe that the brain is extremely plastic. And yes, there might be a lot of brain issues caused from withdrawal, from tapering, a lot of side effects, a lot of impairment. But I do not believe it's permanent. I believe the brain is incredibly plastic and is able to adapt and change. And so I will not, I don't, I think there's a role of healing, for anyone experiencing these withdrawal symptoms. Is taper period tied more to period of time on antidepressants or Effexor specifically? Well, it's multifactorial. It relates to those two things, right? So how long they're on the antidepressant, the risk of the antidepressant. Although generally at Outro, we consider most of these to be quite high risk, and so we'll taper carefully regardless of which antidepressant it is. We also individualize it based on your experience tapering, if you have already, in terms of your sensitivity. We might even grade your sensitivity to the withdrawal, and that might inform the pace that we taper at. But these taper plans are very flexible, and so that's why we meet regularly with you to make sure that the pace is comfortable for you. We track symptoms. We make sure we make the best educated choice, and work on that together in terms of the actual pace of the taper.
And I think that answers Claudia's question, which hyperbolic taper is best to follow, the fast, moderate, or slow. It's highly individualized based on the length of time on medication, the type of medication, and your previous withdrawal or symptoms that came up when you tried to taper in the past.
Right. There's no just blanket taper plan. We want to impress that on you. We really want to individualize it and make sure that it's a shared decision-making kind of process here. What about health risks specific to staying on Effexor? Dementia risk? Apologize if I covered this already. So it's a great question. I would say medically, there are a few. So the first one is increased risk of bleeds, primarily upper GI bleeds. Sometimes we worry about patients with a history of stroke. We worry about, at times, pregnancy. We worry about, like postpartum bleeds. We get concerned about post-surgical bleeds. That's a possibility. Particularly in elderly, frail patients, hyponatremia that can lead to, which is low sodium, that can lead to delirium, confusion. There's also some evidence, serotonin affects so many parts of the body, and there's even a receptor in bone tissue. And so there have been correlations of long-term serotonin use, or serotonin reuptake inhibitor use, with increased fracture risk, specifically along the axial, the spine column, in terms of affecting bone density and overall fracture risk. So those are examples of concerns. Laura asks if there's a risk of post-SSRI sexual dysfunction with hyperbolic tapering. I'm sensitive to the abruptness of the tapers, and I think that causes a lot of the issues. So I think as long as the more slowly that you go, the less you're shaking up the brain, and the less you're shaking up that homeostatic set point. I think the less likely you are to experience a lot of these sequelae of getting off of the drugs too quickly. You need to ease your brain into it. The brain likes stability, and doing it carefully and cautiously, I think, makes all the difference, even in things like post-SSRI sexual dysfunction. Yeah, to answer this question here about tapering patients who have been on Effexor for decades. Yeah. This is super common. I mean, this does not matter. This is very common. I'm actually more happy to care for patients who have been on these drugs long term, 10 to 20 years, because we can definitely help them. We can definitely help get them off their drugs successfully. The tapers may take a year or two, but that's okay. It's been 10 or 20 years on the medication. I think it only makes sense. Yeah, and I'd love, maybe for you to maybe eventually join one of Mark Horowitz's webinar to get his perspective on these things, because he's such a leader in this field, having just published the modestly prescribing guidelines and really causing a seismic shift in how tapering is handled in the UK in terms of the national recommendations. So I think the unique thing about Outro is we have real experts in this area who have had personal experiences as patients potentially, but are leaders in this field in terms of how to do this successfully. We're the only ones who I think have a lot of clinical experience and also have published in the area and have a real a scientific approach in getting this done and done well. I've successfully gone cold turkey off venlafaxine and remained off for 5 months, but my husband says without my antidepressant, I have an edge. Yeah. Yes. And so there is a distinction. It is possible if you were on this drug for a long time that there could be Yeah, so yes, so could it be withdrawal or relapse or something else? It's possible for it to be a sort of a protracted withdrawal. We see this in patients who abruptly discontinue their antidepressants, is that they're at higher risk for protracted forms of withdrawal, so post-acute withdrawal. So I think the slower the taper, the less likely the withdrawal is to progress to that protracted or post-acute state. It's also proportional to the time you're on the medication. And so all that is to say is that it's possible that's a post-acute withdrawal, and not necessarily your pre-medication baseline before the medication. What would you say to a patient who's on 150 without side effects and managed to taper to 57 milligrams, but is now suffering from debilitated withdrawal anxiety and what now wants to quit tape? Yeah, and up dose to 75. So one of the things we wonder here is, first of all, how are you doing in terms of the debilitated withdrawal? Is it starting to improve? Is it starting to get better? Are you seeing a little bit of a window of time that's kind of growing and expanding during the week where you're doing a little bit better? We rate this numerically with our symptom tracker. So we also wonder at what was the lowest dose at which you were actually doing quite well, and we might consider reinstating at that lower dose and stabilizing there for maybe a little time, maybe a month, maybe 2 months, maybe even 3 months. And now that we know that, we know how that withdrawal happened, we can go much more gradually, following that hyperbolic method to make sure that you're able to get down to the next step. That's really individualized for your personal kind of risk in terms of withdrawal.
We're getting a lot of questions about reinstatement. So I was wondering if we could touch on that, Brian, a little bit more about what reinstatement looks like, how long being off of a drug can we reinstate, and kind of what your general guidelines and practice are for that.
Yes. So there are many options. There are many directions we can go. So we reinstate. There's reinstatement when the patient's in acute withdrawal, right? And there's reinstatement when the patient is experiencing protracted withdrawal, which may be 3 to 12 months off of the drug, and they still feel like they're experiencing withdrawal symptoms. It's very individualized. It depends on a number of factors that we assess. It depends on as I mentioned, the trajectory of the withdrawal symptoms. Are they getting better? Are they not better at all? The impairment in terms of everyday functioning. Uh, it depends on we look at the historical course of the taper to assess when you were doing well and what we might reinstate to. We also consider the pace of reinstatement because there are many paradoxical reactions when we do reinstate, where if we were to start the dose that they were doing well on immediately, let's say they're doing well on 100 milligrams of venlafaxine and they've been on 0 for 6 months. If we were to immediately start the 100 milligram dose, some patients get a paradoxical reaction where they feel worse. So we like to cautiously introduce the medication and then maybe increase every week with weekly monitoring to make sure that it's working well for the patient.
Right. And then there was another question that came up of, do you provide or does Ultra provide virtual care? Could you speak on that a bit?
Virtual care is our thing.
Yes.
Yeah, that is what we do. We are a virtual care model. We are rapidly expanding, and we're growing our level of care, our resources, and we have lots of plans and goals. But this is a virtual care model, and that's why we can really help with access. Yeah, I'm seeing a lot of just concerns of long-term side effects of these drugs, carb cravings, concern for cardiovascular risk, osteoporosis, cataracts, all long-term risks. A lot of people just feeling, I think, like they've really been harmed or hurt by medications like Effexor, and it's really difficult, to see how these drugs have affected people. But you know, we really feel like we can help with that journey.
There's many questions coming up about when we come off of the drug, what do we replace it with, so to speak? And so, Brian, I think we can both kind of speak on that, what comes after coming off of these drugs and how do we what's the off ramp, so to speak?
Yes. So there are many schools of thought. I'm a little bit more of a purist in terms of avoiding adding new psychotropic medications to help alleviate the distress or symptoms that might be residual after the taper. Because anything that's psychoactive, I feel there's a risk of dependence and going down the same cycle of potential withdrawal and long-term effects. There are potentially alternative supplements. I've had success with like L-theanine, for instance, lavender root extract. There's certain options, certain targeted multivitamins, but very often it's lifestyle modification that is essential. Maybe Charlotte, you can speak to that a little more.
Yeah, absolutely. There was a great question about are there anything that especially might help symptoms of withdrawal while tapering, such as exercise, hydration, supplementation? Bryan touched on supplementation, and that's something that we can address on a case-by-case basis, here at Outro for your unique needs. Extra sleep, I think, is a really powerful thing, making sure that we are protecting our sleep. Many people find that when they come off of these medications, they find that they need more sleep than maybe they did before. And maybe there's a repair process happening. SSRIs and SNRIs can also impact the architecture of our sleep over the long term. So there's a recalibration back to baseline that can be occurring. Exercise is an incredibly beneficial antidepressant, anti-anxiety. There was a huge meta-analysis of different treatments for depression and anxiety that came out, I believe, just this year, that actually looked at dance as the most powerful antidepressant treatment that's out there. And so thinking about when we move our bodies, we produce a neurotropic factor called BDNF, which colloquially I joke is called like miracle grow for the brain. It helps promote new neurogenesis or new neuronal synapses. And so when we think about the impact that exercise movement practices can have on the brain, there can be an incredibly profound, powerful benefit, both for depression, anxiety, as well as for things like OCD and PTSD. So definitely think that there's a huge toolkit that we can explore of different lifestyle modifications that can help. And again, really think about building a robust toolkit of different strategies for managing withdrawal symptoms when they do arise during your taper.
Yes, super important to pair the taper process with interventions to optimize just, first of all, your environment and reduce unnecessary stress, improve your physical and your overall health. And there's all sorts of things that we recommend.
So we'll
But this,
start to wind down. There were so many amazing questions. So please feel free to reach out to us on Instagram if you felt like your question was not addressed. Or you could reach out to us via email, via hello@outro.com for different questions. There were some wonderful comments or questions about working with Outro in a professional capacity. Please feel free to reach out to us. We're always looking to expand our network of peer support advocates, of clinicians in the field, of trying to do more education for clinicians in the United States. We are hoping to bring some sort of coaching program to those who are outside of the United States in the future, so we can really service a larger base of patients, understanding that many of you are tuning in from all over the world. And we are just so grateful to each and every one of you for being here, for asking the challenging questions, for being curious about what comes next and how to best support yourself on this journey. So, a heartfelt thank you to each and every one of you.
yes, thank you, everyone.